meeting of this committee, the task force, to make guidelines on fluid resuscitation in countries with limited resources. And I finally came to conclude that my emergency department in Rotterdam is also of limited resources. And so that's already tricky because we don't have a lot of tools. Well, we could have, but we don't use them in the emergency department. If you talk about fluid resuscitation, you're talking about cardiac output. Let's not mix everything together. The only reason to give fluids in these patients, and we're talking about shock, of course, is to increase your stress volume, increase venous return, resulting in an increase in cardiac output, and everything else should be the result of that. Well, is an abnormality in flow a real problem? Well, Max Ariwal, already a long time ago, one of the godfathers of critical care, already said the basic mechanism underlying all forms of acute circulatory shock is a reduction in flow and inadequate tissue perfusion, with the ultimate result, a decreased delivery of oxygen to the capillaries where they can exchange with cells and mitochondria. So in the definition, the decrease in flow as a mechanism in shock is very important. And in the recent guideline we produced as European Society, we also said that flow is a very important, or limitations in flow, a very important basic mechanism in shock. But the approach to this flow problem is almost a no-brainer in many circumstances, in many doctors and nurses. It's like fluid is some kind of a recipe to solve every problem. And we go about, we do not go about what is the real clinical problem. And so I think the approach should be different. The approach should be first define your clinical problem. And we're talking about fluid resuscitation. What's the clinical problem? Increased lactate, no urine output, abnormal peripheral circulation, obtunded mental state of the patient. We have so many of these problems that usually are not that difficult to recognize in your critically ill patient. And then the next question you should ask yourself, would this problem be likely solved by an increase in perfusion pressure or an increase in cardiac output, or both? And so, for instance, we keep calling neurogenic shock a shock state, but I hardly see patient die. I've never, to be honest, never seen a patient die in spinal shock. They have profound hypotension, but they have no flow abnormality. The only thing these people need is a little bit of blood pressure augmentation and hardly need any fluids. They need some vasopressors. That's one of the extremes. And so that's what you have to ask yourself. Is the patient in need of pressure or in need of flow, or maybe in both? And then the next question is, okay, if this perfusion pressure is needed, or this increase in cardiac output, what's the best way to do it? Is it the best way to decrease post-capillary pressure, in, for instance, cardiogenic shock? Is it best to just increase mean arterial pressure with a vasopressor? And if I need more cardiac output, is it best to give fluids? Is it best to improve myocardial contractility? Give an inotrope, put the patient on a ventilator, put the patient on ECMO or an LVAD, stuff like that. That's the question you should ask yourself if you have defined your problem. And then finally, and that's usually forgotten because we have these weird endpoints, what's the effect? Did my problem go away, or did it resolve partially or completely after I did my intervention? And if you then look at what we use to assess the efficacy or efficiency of our fluid resuscitation, and this is data from the recent Venice study, that's really disappointing, because the indication to give fluids in the majority of patients was hypotension, but also the effect of fluid resuscitation on blood pressure is by far the most widely used outcome parameter of the effectiveness of the fluid resuscitation. next to urine output and a decrease in heart rate. The specificity of a decrease in heart rate in resolving a microcirculatory problem after fluid resuscitation is very doubt. You can doubt that very strongly. At least physiologically, there is no relationship, and at the end I will come back to it. So whether these are adequate endpoints to assess the efficacy of your problem, I don't think so. But still, we use them in clinical practice in the majority of patients. And in addition, and that's even more cumbersome, we have no safety parameters. Well, we don't use them. We have them, but we don't use them. In almost 3/4 of the patients, and of course this is a critical care, this is not the emergency department, but it's to, let's say, set the stage on how we do it. There were no safety measures whatsoever in the majority of these patients, and if anything was used, it was CVP. Well, that's maybe the most sensible parameter to use as a safety. Saturation is quite late. If you use saturation as a safety parameter in fluid resuscitation, basically what you're doing is you're flooding the lung, and at the time the lung is flooded, you say, oh, let's stop fluid resuscitation. So that doesn't make sense. That's way too late. And even more disturbing, whatever the outcome of the first fluid bolus, we always give a second. Whether the effect is positive, the effect is unresponsive or uncertain or negative. We always give it a second one. So there is no safety limit and there's always a second bolus. That's not a very reasonable use of fluid resuscitation when you use this approach. When the approach should be, what's the clinical problem and did my intervention solve it, then this is not the right way to do it. And so in an accompanying editorial, well, the editorial was out before the study was out, to be honest, we wrote that this should be a wake-up call. We need to acknowledge that we hardly understand the basics of this complex area. And I think that's absolutely something that we should be worried about. We need to define and redefine fluid resuscitation also in the emergency department. Not only what's the best way to do it, but also what are the indications to resolve problems. And we need to start and do studies on this. The main problem is that we have a lot of parameters that can go wrong and that we can correct. CVP, blood pressure, saturation, you name it, I can correct it. That's the basic of intensive care. But the real parameter that tells you that there is a problem in the exchange of oxygen in your microcirculation, that's the ultimate goal. If you go back to the Max-Harry-Weil definition, that's the ultimate goal, that you have adequate oxygen exchange or nutrient exchange in the microcirculation. We are lacking parameters for that. Blood pressure we know, CVP we know, lactate we know are not a very specific indicator of all of this. And Max-Harry-Weil introduced altermentation, mottled skin, oliguria, and of course his most favorite parameter, lactate, but we all know the limitations of these parameters, either brought about putting in a tube and sedating the patient, or urine output that is not indicative of anything in the first hours, and you need it now and not in 2 hours, and urine production. And of course, they're not all present at the same time. You can have normal tension. Usually in shock, you have somewhat increased tension, blood pressure, where you have altered perfusion underlying an abnormal microcirculatory perfusion. So it's not all there in your shock patient. But we know from physiology and pathophysiology that the shutdown of the skin is one of the first things that we do, at least, when we get hypovolemic. When we are, and hypovolemic, I mean have a decrease, acute decrease in venous return and cardiac output. That's not hypovolemia in a sense as a loss of circulating volume, that's hemorrhage. But as we know, in sepsis, you have an increase in your unstressed volume, and so your venous return decreases while your total blood volume is still intact. And so the problem is the decrease in venous return in the acute decrease in cardiac output. And then the skin is the first to have signals, not the blood pressure. because due to this activation of your sympathetic nervous system, usually your blood pressure goes up a little bit, especially in the beginning. This study from the group from Nathan Shapiro from Boston already showed, if you look at the significance of an indicator of hypoperfusion and abnormal metabolism, lactate, and the macrohemodynamics blood pressure, then if you look at outcome, ultimate survival or mortality, lactate is much more predictive than the blood pressure signal. We redid this study in the ICU. Tim Janssen did this study, and we found exactly the same. So the indicator that at least is related to something like metabolism, it's much more predictive than a global hemodynamic. So the global hemodynamics are not very good indicators or even parameters of efficiency of your fluid resuscitation. Despite that, there's a lot of hemodynamics in the surviving sepsis guideline. Luckily, much is disappearing from the guideline again, but like the blood pressure, the urine output, and the central venous pressure is basically macrohemodynamics, and very questionable whether they improve outcome. At least central venous pressure should never be the target of your resuscitation, at least a fixed number in central venous pressure. This is a study by Namke Vellinga from Leeuwarden in the Netherlands, who looked at the effect on microcirculatory perfusion and elevated central venous pressures, and that's not a good idea. If you follow the surviving sepsis guidelines in increasing your central venous pressure with fluids, then basically you're shutting down your microcirculation. That's not the goal of your treatment. And once you have this normal microcirculation, and this is again critically ill patients in the intensive care department, not the emergency room. We didn't do this study over there. Once your microcirculation is normal, then giving fluids and resolving a possible problem of fluid responsiveness won't help you. So these were, this study is in press now. Eva Klein, who will do her PhD on Friday, Eva Klein did this study, and all these patients had a clinical problem. The blood pressure was low, there was no urine output, the lactate was not falling, all these clinical problems that we are used to use in our patients. And then she gave fluids and resolved fluid responsiveness. Well, if you look, I don't know if the cursor is, yeah. If you look at the MFI, these patients had normal MFI. And by looking at the MFI effect in the responders, that doesn't help. If your microcirculation is normal, making it more normal by giving fluids, that's not, let's say, a very smart endpoint of your resuscitation, although the increase was significant. Yeah, it does something. But who needs a microcirculation more than normal? That doesn't make any sense. And so if your microcirculation is normal, then please do not give fluids or increase CVP. And especially do not increase CVP, it will only get worse. And so we took a very simple approach. If the periphery is the first to shut down in problems, would the response of the periphery to a fluid bolus in relation to sepsis management be a good indicator of success? And so could you use the periphery to indicate efficacy of your fluid resuscitation? And this is the interim analysis of 87 patients. The study is still ongoing and is running at the Catholic Hospital in Santiago in Chile. And Barbara is the first doctor in the study, together with the guy who does all of that over there, Glenn Hernandez. So it's 87 patients up to now. Mortality is 11%. That's a basic mortality in patients like that. The volume administered in 2 hours is median 2 liters. The heart rate at baseline 110, and the decrease in heart rate significant, 12%. Lactate 3.5 at baseline, and the decrease in lactate 34% as a median. And the interquartile ranges are next to it. Now, if you look at Modling score as developed in France, Patients that always have a normal Modling score have a low mortality, and patients that have abnormal and don't normalize their Modling score have a 33% mortality. Not a huge mortality signal. If you look at lactate, basically the same. Lactate decreases in all patients. It's not extremely abnormal, but 3.5 is absolutely abnormal. And the significant change in lactate doesn't really discriminate in mortality, as you can see from these numbers. The primary focus was capillary refill time. 67% of the patients had a normal capillary refill time, and 24% of the abnormals cleared or normalized their capillary refill time, and this is the mortality. And now it becomes somewhat more clear. If you have an abnormal capillary refill time, more than 4 seconds, and you don't normalize it after a fluid resuscitation, your mortality is about almost 60%. When you have a normal capillary refill time or normalize it, mortality is around the baseline mortality of the whole group, around 8%. So that's a huge difference in mortality between the two groups. So yes, indeed, the effect of the signal of the periphery in response to the fluids could help you to assess efficiency. And this supports the general view that Martin Dunzer, Jukka Takala, and Andreas and me have on what should be the endpoint of your fluid resuscitation or your resuscitation in general. Well, we think we should leave the macrocirculation. That's not the intention of the ultimate goal. The ultimate goal is tissue perfusion. And so if you're at the right side of the slide, and so the indicators of adequate tissue perfusion are normal, then please don't worry too much about the macro hemodynamics. Because as John Inch introduced, the coherence is more related to the effect of the macrocirculation, to the micro than the macro. I would rather have a normal microcirculation than a normal macrocirculation. Thank you very much.